right, hello everybody. Welcome to Pediatric Grand Rounds. This will be our last Grand Rounds of 2020. So I want to wish everybody Happy New Year, Happy Holidays. Look forward to reconvening in January. And I'm going to hand this off to Dr. Ted Ruhl, our Division Chief for Infectious Diseases, to start our program for today. Ted.
Thank you, Dr. Hirsch. It'll be a real pleasure to moderate this Grand Rounds today. We are very fortunate to have three speakers who will each bring a different perspective on pediatric considerations for SARS-CoV-2 vaccines. Obviously, a timely topic, and again, I really want to thank them at the beginning and the end for carving out time to speak with us today. So I will introduce our three speakers in turn just before they speak. Our first speaker is Joel Ernst. He is a professor of medicine and chief of the Division of Experimental Medicine. After training in medicine, infectious disease, as well as hematology and oncology, he joined the faculty at UCSF and established a research program around host pathogen interactions and immunity, with research that focuses on the rational design, development, and evaluation of new vaccines, and specifically around tuberculosis. But needless to say, he, like many, has turned some attention to SARS-CoV-2, and I'm really looking forward to his perspective on pediatric considerations for vaccine development for this pandemic. So thanks, Joel. I'll hand it over to you.
Well, thank you, Ted, and thank you for the opportunity. I'll share my screen here and get started. Is that showing like it's supposed to now?
Yes, that's great.
Okay, good. I'm not accustomed to speaking with pediatricians, partly because my own children are already grown. So I've included some special considerations from pediatrics from an internist's perspective, and I won't be comprehensive about those, but be happy to discuss a lot of the points. So these are just the topics that I'll bring up. I want to talk a little bit about the antigen and how it's been modified for the vaccines, the RNA itself, lipid nanoparticles that are all the constituents of the currently soon to be authorized vaccines, and then a little bit about potential for antigenic variation, what we know about the virus and the possibility that we'll need to modify vaccines in the future. And then I'll touch on a few specific points about pediatrics, and like I said, be happy to talk about any others. So I wanted to talk a bit about the antigen because there's not only some unique features of it, but some, I think, very clever and innovative approaches that were taken. And among other things, one of the reasons that it was possible to develop SARS-CoV-2 vaccines so rapidly is because of background work that was done in other fields, including on MERS and SARS-1. And some of that included structural biology work with the spike protein of the MERS coronavirus, which is shown here on the left in the space filling diagram. And the receptor binding domains here are shown in green. And the receptor binding domains, first of all, the spike protein exists as a trimer, and the spike protein receptor binding proteins are largely buried and not exposed. But because the structure of the trimer is actually unstable, there's sort of a stochastic unfolding and exposure of the receptor binding domain. And in the next slide, I'll show you the significance of that. On the right is a more recently obtained structure of the SARS-CoV-2 spike. And in the bottom diagram, it basically shows that one of the three receptor binding domains is in the so-called up position, where it's exposed and available for binding to the host cell receptor ACE2. The cartoon here in the upper left shows, again, modeled from the MERS coronavirus spike protein, the various conformations adopted by the trimer. And what I want to point out here is that once all three receptor binding domains are engaged, the trimer changes its conformation dramatically and becomes this long helical structure that has a really dramatic change in the in its conformation. Now, in the course of trying to understand the structure of the MERS coronavirus spike, cryo-electron microscopy was used to visualize the structure. And what the investigators noticed is that a fraction of the trimers were in a conformation that now we know is the stable pre-fusion conformation. But then in these upper rows here, kind of highlighted in brick red, are that some of the molecules are actually in that extended pre-fusion conformation. And for the perspective of making a vaccine that generates blocking or neutralizing antibodies, that's just wasted. In other words, you don't really want to have protein in the wrong conformation. So the protein engineering approach was to generate 2 proline substitutions at this junction that's actually distant from the receptor binding domain. But in these 2 cryo-EM kind of image collections titled MERS S2P and SARS S2P, it basically shows that 2 proline substitutions has stabilized the trimer in a conformation where we actually really want it with respect to a vaccine to generate blocking antibodies. So this was background work. This was published in 2017, but it was very easy to recall this work and to implement those proline substitutions in generating the antigen for the 2 RNA vaccines that are available now. So I'm going to refer to the vaccines, and I'm going to focus on the RNA vaccines. I'd be happy to talk about some of the others in the pipeline during questions. I'm going to refer to them by their sponsors, so Pfizer, BioNTech, and Moderna, because I think those are the terms that most people kind of use to refer to them. So the antigen in both is, as nearly as I can tell, identical. It's the full-length spike protein. So some people would reason that just the receptor binding domain should be sufficient, but there was a very interesting result of the phase 1, phase 2 BioNTech trial that showed that there was greater reactogenicity and toxicity in a vaccine formulation that only encoded the receptor binding domain. So they basically went forward in phase 3 trials with the full-length protein, and that's the same that's in the Moderna. And so, as I just mentioned on the prior slide, both of these vaccines have RNA coding this stabilized pre-fusion conformation, sort of modification of the spike protein. So the RNA is also modified. So as I alluded to, these are both RNA-containing vaccines, which is another novel approach to vaccine development and application. And early work by Drew Weissman's lab and others, Drew is at Penn, realized that our cells have mechanisms for recognizing foreign, mainly viral RNA, and generating an innate immune response, including inflammatory cytokine production. So Drew Weissman and several others discovered that certain modifications of uridine were compatible with incorporation into RNA, but those modifications dramatically decreased innate immune recognition and pro-inflammatory cytokine production. So both of the vaccines, both of the RNA vaccines actually incorporate modified RNA in order to reduce inflammation and local side effects, obviously. As a kind of additional benefit, the substitution of these modified uridines also stabilizes the RNA from degradation, and it has several other beneficial properties. So again, background work, kind of just basic investigation and discovery, came in very handy in the rapid development of these vaccines. I want to talk about the lipid nanoparticles because there's also a good bit of innovation here, and this is not something that we're completely familiar with. So the simplest lipid nanoparticles are liposomes, and you're probably familiar with those. Among other things, there are liposome-encapsulated drugs, including amphotericin B, for example. And liposomes really are just, for the most part, phospholipids that spontaneously form a bilayer and form basically a conformation of a closed bilayer or a sphere by virtue of their polar head groups and association of their lipophilic tails. They've got the capacity for a payload in the lumen, but they've got other disadvantages. So several years of lipid chemistry and engineering have generated more complex lipid nanoparticles. And what's fused for both of these RNA vaccines is a complex of 4 lipids, a so-called ionizable lipid, and that's these blue balloon-like things here that are associating with this strand of RNA. It's ionizable in that it is neutral, it lacks a charge at neutral pH, but in the lower pH of endosomes, basically becomes charged and actually releases its grip on the RNA in that context. Both of the RNA vaccines that we have also include cholesterol, a neutral phospholipid, and then a modified lipid modified with the addition of polyethylene glycol, just to basically keep the structure intact for a little bit longer. Just very briefly, the generation of lipid nanoparticles is really an engineering feat because you have to take lipids in an organic solvent, RNA in an aqueous phase, and get them to essentially organize in the way that you really want them to do. And so there's really been some very innovative and pretty brilliant engineering involved in doing that. That said, this is actually a difficult step to scale. And so that's one of the reasons that we don't have more doses of the RNA vaccines readily available. In terms of how lipid nanoparticles work and how they deliver RNA, they basically get incorporated into cells after injection. They are incorporated by endocytosis. And actually, all existing evidence it pretty much suggests that this actually happens in skeletal muscle cells after an intramuscular injection. There's endocytosis. Endosomes undergo a pH change where protons are pumped in. The lumen of the endosome becomes acidified, and that actually results in a kind of dissolution and reorganization of the lipid nanoparticles and release of the RNA. The RNA then is translated into protein in the muscle cell itself, but then, partly due to probably muscle cell death, as well as several other mechanisms, the antigen gets incorporated by dendritic cells, delivered to T cells and B cells and lymph nodes, and basically that's where the adaptive immune response gets generated. One of the side effects of both of these RNA-based lipid nanoparticle vaccines is local or regional lymphadenopathy, which I think basically suggests that after intramuscular injection, the appropriate things have drained to the local lymph node and an appropriate response is generated. I don't want to go into too much detail about the lipids in the 2 RNA vaccines, other than to say that they're very similar but not quite identical. The similarities between these two vaccines are probably greater than their differences. Just want to close before talking about pediatric aspects about some recently emerging information on the potential for antigenic variation. I think a lot of people dread the possibility that we're going to have not only a seasonal influenza vaccine, but a seasonal coronavirus vaccine. There are several reasons to think that the coronavirus is going to be behaving differently than influenza. First of all, it's not a segmented RNA genome, so pieces of viral RNA aren't sort of exchanging in cells. Second, uniquely, the betacoronaviruses are the largest RNA viruses that we know. And they are also unique in that they have an RNA-dependent RNA polymerase that actually proofreads. So you're probably aware that, for example, in the case of HIV, the polymerase that is responsible for replication of HIV is incredibly error-prone. And in fact, the RNA polymerase in betacoronaviruses actually has a proofreading function, so the rate of mutation is much lower. That said, the potential for mutation exists. And one, I think, fairly innovative study that was released just recently was done by engineering every possible amino acid substitution into the genome and the sort of subgenomic portion encoding the receptor binding domain in order to ask the question in advance, what amino acid substitutions could be tolerated by the spike protein and still be able to bind cell surface receptor ACE2. And so what that did is generated several hundred amino acid substitutions. We know which ones now are compatible with ACE2 binding as well as appropriate sort of trafficking and folding of the protein. So now we know what to watch out for with respect to viral mutations on the way. One of the ones that was uncovered by that is a naturally occurring spike variant called N439K, which actually is able to evade antibody-mediated immunity while maintaining fitness. Now, a recent study, actually more recent than what I've just cited here, suggests that the polyclonal antibodies generated by the existing vaccines can still recognize this variant. So that's good news. But I do want to sort of alert everyone to the idea that right now, there hasn't been a lot of pressure on the SARS-CoV-2 virus to very, very much in order to evade adaptive immunity because we don't have herd immunity. We don't have a lot of immunological selection pressure. The more people that we vaccinate with very similar vaccines, the higher the selection pressure will be. And I think that we can expect to see some antigenic variation and escape and requirement for modifying vaccines in the future. Some of you who may be tracking this know about this B614G mutation that arose very early and has kind of enjoyed a global sweep. And it seems to be more fit from the perspective of binding our cell surface ACE2 receptor and replicating. It doesn't seem to make people more sick, but it does seem as though it transmits more efficiently. Well, the good news is, and the way that it transmits more efficiently, and these blobs here kind of demonstrate the situation. So this is a top-down view of the spike protein with the receptor binding domains all here in the 3 down. In other words, all 3 members of the trimer are in the down position. But as I mentioned earlier, there's this sort of spontaneous unfolding, and a certain fraction have one of the 3 members of the trimer in the up position. It turns out that G614 mutation results in a higher frequency of 1 up, in other words, exposed receptor binding domains. And since most of the antibodies generated by the vaccines are directed at the receptor binding domain, this means that they're actually, in these viruses, they're actually more susceptible to neutralization by the existing antibodies. So that's good news. But again, it's something to kind of watch out for as we generate a higher frequency of immunity in the population. So just with respect to some special considerations for your populations, as you're, I'm sure, painfully aware, there's little data on safety or efficacy of any of the COVID-19 vaccines in children so far. Both sponsors of the RNA vaccine trials are now exploring and beginning to submit draft protocols for pediatric trials, and so that will be coming. I think one of the questions that must be on the minds of pediatricians is whether MIS-C is going to be something that might be seen as an adverse effect of vaccination. Obviously, it's associated with COVID-19 infection itself. I think it's difficult to evoke very much confidence or a crystal ball about this, but I'll just point out that none of the current COVID-19 vaccines in advanced stages of development are live or attenuated viruses. So I think a live or attenuated viral vaccine might actually hold a particular risk of MIS-C as an infrequent complication. I think that the one possibility that I think hasn't been excluded just yet, but if MIS-C is actually due to autoantigens that are cross-reactive with the SARS-CoV-2 spike protein, then I think we have to be alert to the possibility that by vaccinating children, there may be a certain frequency of vaccine-induced MIS-C. We certainly hope that's not the case. And I think more likely, more cases of MIS-C will be prevented by vaccination than induced by vaccination, but I think we need data in order to tell that. So I will close there, and I'll be happy to field questions when the time comes. Thank you.
Thank you very much, Dr. Ernst. I mean, I think I probably speak for many when I say that was the clearest and most succinct explanation of the mechanisms of those 2 our current vaccine kind of models that I've heard to date. Really appreciate that and look forward to questions after. And on that note, I want to do a little housekeeping I neglected to do at the outset, which is to say, please collect your questions and answers and post them in the question and answer box, where we've really strategized to leave time for discussion at the end of these presentations. So I hope people bring their good questions to it. And for those that joined late or that know of others that missed it, the recording will be posted online for people to view at a later time. So thanks again. I will now turn to introduce Ayanna Bennett, who is our second speaker. Ayanna is the Director of the Office of Health Equity at the San Francisco Department of Public Health. You'll note I called her Ayanna. Dr. Bennett did her training in pediatrics here at UCSF, and as she reminded us at the beginning here, I was actually the intern when she was the sub-I, right at the turn of this millennium. So we have a long relationship that goes back, and she's definitely one of us. After graduating from this program, she founded a nonprofit called the 3rd Street Youth Center and Clinic in San Francisco's Bayview Hunters Point, where she served as medical director and then executive director for 12 years. She then joined the DPH in SF in 2015 and established the Office of Health Equity in 2019, where she remains in the lead. So her primary, really important role in our community. But of course, for 2020, she rose to serve in a big way around the COVID-19 response, serving as incident commander. So we're lucky, very lucky today also to have her. She can bring both of those perspectives to us, and she'll be touching on the epidemiology of SARS-CoV-2 among children in the Bay Area, and a little bit on its implications for rolling out a vaccine to reach that population. So thanks Ayanna, and I'll let you comment on your background there. I think it's real life.
I am my expertise is practical in this area, both for the communities that we're going to be trying to vaccinate and for what we've done and learned about how to protect children during this pandemic. So that is the direction that I'm coming from. So let me share my screen, just a moment.
Okay, so I'm going to copy and paste it. Copy image.
All right. So I'll be talking, this is a very formal sounding title that Ted gave me, but we're going to be talking mostly about what's happened in San Francisco. The experience here has not been greatly different, I think, than it has been in the rest of the Bay and really in the rest of the world for those who have had students back in class. So just to give some overview and context, the points about where and when and how children get infected are within the context of some things that have turned out to be clearly true across the board. So most transmission is in households, and that's both for adults, but very especially in children. We were seeing infections during the period where children weren't really going anywhere, and those were in the household, and it has not changed greatly since schools have opened. In-school transmission happens, but it is not typically between students. There have been very small clusters, but not spread throughout classes in the way that you might have expected if that were true. Children are infected by adults, much less the other way around. And of course, most of the adults in their lives are at home. And we are in a current surge, which we have not hit the peak of. And our experience from the last two surges is that increase in adults, middle-aged, and then young adults over the summer is followed by the increase in younger children as those infected adults go home and later infect the children in their lives. So we had 91 schools open in the last couple of months, and we had 75 learning hubs open. If people don't know, the learning hubs were the pods that the city set up in order to keep students having some learning before we were able to open schools. And our experience from those learning hubs was very instructive in how to open the school safely. And I believe I have some evidence that we actually did do that. So students and teachers participating in in-person learning by grade level. If you see, most of the schools that we opened initially were all in the younger cohort. And that was a deliberate safety consideration since that group has shown less severity, but also less transmission. And then middle schools opened later, and then high schools. And many of those in the private schools are, of course, a mix of middle and elementary schools. So that at this point is somewhere, I think it's a little higher now, between 18 and 19,000 students in school. The cases among students and staff in our K-12 schools have been really, really remarkably low in many ways. So we had 30 schools who reported more than one case. I think this is now 2-week-old data. We had 30 schools with more than one case, which means there were many, many, something like 130 without any. And student cases are at a relatively low rate. We certainly don't have an enormous number of children in school, but only 28 cases that we trace to school is actually really quite low, and teachers not even that many. That means that we quarantined the cohorts that those students were in. And so of all those 36 cohorts that got quarantined, that's 435 students out of the 18,000. So what do we know about who those children are? And looking forward to what's going to happen as this pandemic surge rolls through, what can we expect our January will look like? So we know that it will be geographic. This has been geographic from the beginning. As soon as we were able to get geolocation on board, it was very clear that we had hotspots. In the beginning, in the first surge, and even partly through the second, we had mostly cases in the southeast sector, almost entirely. That is no longer true, but it is still the area of highest concentration. So because we know most incidences are in household, we know that places where we have crowded housing are much more likely to have high levels of transmission. Those cases are, I wouldn't even say localized, I'd say hyper localized, because it looks like all of Bayview Hunters Point, but it is in fact not. It is maybe 3 or 4 census tracts within that area. That has been loosened somewhat. The cases are now in every area across the city, but in some of those, it's really a very small number. And despite spreading across the city, the gap between neighborhoods is actually widening. So this is comparing the first and second surge, and what we saw, this actually ended in August 1st when we pulled this data, which is about the peak of that second surge. So if you look in that first few months compared to even just 6 weeks of that second surge, we had a much higher number of cases altogether, but a lot of that was fueled by these hyper-localized hotspots in neighborhoods, Sunnydale, Bayview, some in the Mission, some in the Excelsior. So if you look at the numbers of COVID cases that constitute those, they're not enormous in the small age group, that's 0 to 17, but they are getting more substantial over time. So we barely had 100 in the beginning, and now we're probably going to end up in the several hundred from this one. Oh, just one point on that. Despite many people have a somewhat outdated notion of who lives in those neighborhoods, in that Bayview sample, in the Excelsior, in the Tenderloin, the majority of people getting infected who, and the positivity is highest in the Latinx population, even though it's the Latinx population where they are not the majority. So they are still the majority of the cases in almost every circumstance. The COVID cases by race, ethnicity, the point I just made, they're still, despite this variation in area, are still happening really overwhelmingly, even more so in children than in adults, happening in Latino and Latino populations. So we have a big number of unknown, you'll notice. What you're seeing here is, sorry, this is unknown, and that's because we have not because we are not collecting, but in fact because we have some sites that are not set up to be easy collection and at various different providers, but even more so that some people just simply don't want to give us that piece of information. And so there's always going to be a degree of that in every sample, and it is in fact higher than some of our groups altogether. But if you look, there are disparities in this bottom area, but they are dwarfed by the large number in the Latinx community. So we're in a current surge, and it's larger and moving faster than the others. Jim Marks has been a tiny bit hopeful about this very, very tiny flattening that we've gotten in the last couple of weeks. We'll see if that turns out to be anything, but it is already fairly dramatically high. We're in real danger of having that medical surge, which we have planned for but held off for so long. But what is happening to children is not always as evident as what's happening in the general population. But our expectation from those last two surges is that we should start to see that rise in children's cases sometime in the near future if we haven't already started to see the beginning of it. So you should see them coming soon. So just some key points from what we've seen. If you look at September to October, which is the inflection point of the current surge, it's a lot of young adults. That was what happened over the summer, and this is equally in that case. The proportion of cases that came from the 18 to 30 and so that's supposed to be 30 to 40. The proportion under 18 decreased, but the proportion in that young adult, I'm calling a 30-year-olds young, is actually bigger. And then the racial and ethnic disparity is less severe than it was. It's gone up in every area, but in this period, it became less than it had been in the past. And actually the rise was a little bit steeper among white adults than it was among other groups. Pacific Islanders and multiracial also grew, but they're very small communities, so it is not as dramatic and doesn't affect the outcome as much. The geography is still more or less the same. The hotspots are still the hotspots, but now you're seeing the introduction of more significant numbers of cases in places where we had not seen that much. North Beach, Financial District, Inner Sunset, all of you who are still living by UCSF. And what do we know from interviewing? So what I'm going to tell you comes from our contact tracing interviews, but those interviews are somewhat skewed by who answers the phone. We actually have a better response from Latinx patients than we do from some of the other groups. So we are getting a bulk of the information. In particular, we have a slightly lower response rate from white people who are infected, and why that is, I don't know. But if you're looking at where people report they were infected when they believe they were infected at work, as you can see, it's retail, it's restaurants, it's construction. Those are all groups where we've had more than a few outbreaks and concentrated outbreaks within particular work groups. Janitors and environmental services, that is a group that is at some danger in the workforce in hospitals and clinics and is somewhat unacknowledged as healthcare workers, but they are certainly in a high-risk group. And if you look at why that is important, 61% of those people who report that they're working outside the home are Latinx. So they're much more likely to be having work outside the home in any of these environments than others. And then what's happening when they are getting infected at home? It's within their house with family members. Sometimes it's with friends. The friend is big enough there because we are seeing small gatherings, some large gatherings, but we are seeing small gatherings despite everything. And so many people are being infected by extended family or close friends. And 77% of those who report living in large households are Latinx. So a lot of the variation is not necessarily the number of households, but when an infected person enters the household, if there are 7 people to become infected, it's a much bigger impact than someone who is living alone or with a partner. There's considerations for vaccination. I'll wind up. One, transmissions at home. So it's mostly from people who are leaving, the adults in the house. So they don't seem to be significant sources for the other people. So their protection is really the rate of infection in the adults they encounter. They don't seem to have an increased risk of becoming infected. They're not more susceptible to infection as far as we can tell. Probably not a lot less, but definitely not more. So the rate for infection in that under 18 group is about the same as it is for all other groups. Race, ethnicity, Latinx children have the highest rate. We know that. and they are exposed at home, tend to live in larger households. So that is a risk factor that I think we are not always clinically eliciting from our patients. And also white adults, I think, are under-emphasized in treatment. The geography, it's a small number of neighborhoods that make up the majority of cases. It's particularly in children. We do not have children distributed equally throughout the city. There are neighborhoods where the vast majority of children live. And so looking at those neighborhoods as primary would be a consideration. So if you take all those things together, you really do have an argument for equity in that you give the treatment where it is the most beneficial and the most needed, not necessarily spreading things equally. Just a word on, as the equity officer, just a word on vaccine hesitancy. This African-American gentleman here is a lot of the story of vaccine hesitancy. A lot of them have been about whether or not the Latino population or whether or not African-Americans are going to be able to take the vaccine, the fear of being guinea pigs, as a quote from a story about whether African-Americans are going to reject this. I would say that those concerns are real, they're historic, they have been reaffirmed by the field's behavior in various other ways, and some of what's happened in this current pandemic, but they are not alone. That woman in the t-shirt who's agreeing for vaccines is a pretty prototypical member of the anti-vax movement. It tends to be suburban, white, tends to be women. And there are other religious groups that have objections. This is an article from the Catholic Spirit about whether or not the vaccines might have had some relationship to cell lines coming from abortions. So vaccine hesitancy, it does not belong to any group. The motivations for it are different, and we're going to have to tailor our messages for those different groups to allay the fear that they have, whether that's a fear of big pharma and whether or not these are manufactured in some way that's dangerous, or whether or not they can trust you as a provider. Most vaccine hesitancy, where we are successful in getting past it, is about the relationship between provider and patient, not about global messaging. So the degree to which patients are in relationships where there is some respect and they have some confidence in the equity of the service that they're getting, we will not have this as a problem. So if we do, it's a diagnosis of where we already were. All right, I think I made the time limit. I'm ready for questions whenever.
That was perfect, Ayanna, thanks. And I appreciate people posting the Q&A, and I'd say keep doing it. We're assembling already some great questions for discussion. And Ayanna, thank you. Yeah, thank you for that and for being right on time. I love it. Okay, so our final speaker today will be Erica Pan. Erica is also, I guess, one of us. In fact, I met her for the first time the same year I met Ayanna, in year 2000, when she was a fellow and I was at that same intern. Funny that. She did residency, chief residency, and fellowship in pediatric infectious disease here. After some other kind of twists and turns, in 2011, she took over a position as deputy health officer in the Alameda County Public Health Department, where she long led efforts there, specifically with some attention to prevention for epidemics and incoming pathogens, which was time well spent as she led their initial response to the pandemic, of course, the beginning of 2019, or sorry, the beginning of this year. But as of the middle of 2020, she took on some additional rather major roles, and you might have heard about these. She is deputy director of the Center for Infectious Diseases. She is state epidemiologist for our entire state, and she's also been acting state public health officer for some time. So she has a lot of hats. She is insanely busy. We're really grateful to have her time here, but I can think of no one better positioned to give us a real update on the strategic plan for vaccination in our state and some of the first considerations on how kids might play into that. So thank you very much, Ayanna, for joining.
Great, thank you so much, Ted. It's really nice to be in my clinical home at UCSF. So I'm gonna share screen now. Let's see if this works. But yeah, it's really a pleasure. I think some other just quick framing things in response to the great speakers already. Before we kind of get to, thankfully, the good news about vaccine on the horizon, we are at record highs. I think Ayanna was showing this in San Francisco, and certainly in the state. We had over 52,000 cases reported again today. This is about close to 3.5 times our peak last July when we were already really worried. And then you've also likely heard about our ICU capacity, and we've been using ICU capacity statewide to think about what is our, what are our triggers for worrying about hospital surge. So we had the Southern California area, the Central Valley area, and then before the Bay Area, it was Sacramento that all got to under 15% ICU capacity. And then just this week, the Bay Area has indeed hit that as well. So as we account for COVID positives in the ICU, the Bay Area just hit that 13%. So starting at 11:59 tonight, the state order is in effect for the whole Bay Area. I know, thankfully, my prior colleagues had already done a lot of that, triggered that earlier in the Bay Area. And of course, there's variety in all of these regions, but just trying to take into account the diversity of California. Because of the real strains in Southern California right now in the hospital capacity, we're at 3% capacity statewide. So, and I know all of you as clinicians know a lot of your ICU adult colleagues are really exhausted already. And we have, I think, the worst to come in the next couple weeks. So I do want to just take a moment as well to just ask all of you to continue to partner with us to get our messages across. I know the public and we are so tired of this pandemic. It's been almost a year. And people are just really tired of trying to wear their masks and keep their distance and not gather. But we really need people to hunker down for the next few weeks while we, try to blunt this curve. As Ayanna was implying as well, in San Francisco and statewide, we're not really seeing an impact yet of some of these regional stay-at-homes. And in fact, right now, we think we're seeing some of the results of Thanksgiving. But we really need to, as a community, and there's a lot of sort of just not buying into, and we really had to use this blunt tool to say everyone needs to stay at home in order to try to decrease transmission. And we know that it's less outside and everything else, but it's just everywhere you go now is a higher risk of being infected. So we really need people to really minimize any interaction and stay at home. So please help us communicate that. Other quick epi things, as far as MISC in the state, we have about 152 cases reported. Just like the epi has been higher rates in general in Southern California, more of those have been in Southern California than here in the Bay Area, but we have had several cases here as well, and at least 3 pediatric deaths. 2 of those were teenage MISC cases, and very sadly this week, a 4-year-old death, and investigating another pediatric death this week as well. But let's move on to a happier topic, vaccination planning. I wanted to just give you a little bit more of an overview of kind of some of the nitty gritty. It's, I think, pretty opaque and a mystery to some people how it all works as far as vaccine distribution. And I can talk a little bit about what we're doing at the state level to make sure we're getting input from stakeholders across the state. So I can click here. Okay. So again, thank you. Hope is on the horizon. We are really actively working on all this planning in partnership with our local health departments to have quick, safe, and equitable vaccine distribution. And our other key value around vaccine distribution in the state is transparency. So some of our key goals, of course, are to evaluate efficacy and safety of the vaccine. So obviously there are really great measures in place at the FDA and the CDC level to evaluate safety and efficacy of vaccines. I think given what is called Operation Warp Speed and some of the dynamics and concerns, and Ayanna already mentioned vaccine hesitancy, we wanted to take advantage of the great academic network and great experts we have in the state of California to also look at safety and reassure ourselves and our community that no steps are skipped in any of these evaluations for emergency use authorization. So I'll talk more about that in a bit. We also wanted to make sure that we are getting broad stakeholder input. So we have a community vaccine advisory committee, and that's at this point, over 70 different stakeholder organizations from all different kinds of organizations to help us, again, give input into our allocation framework. And the drafting guidelines work group is another work group we have with a great overlap, again, of ethicists, actually Dr. Bernie Lowe from UCSF, many other UCSF partners on all of these committees and work groups to develop guidelines and really start taking whatever the national guidelines are and taking them to that next level of the state to parse out how many of these individuals do we have in the state, how do we prioritize within different categories, and then getting input from the community advisory committee, and then bringing that back and making that recommendation to us and the administration. And then of course we want to be ready to go and distribute and make sure vaccines are distributed quickly as we can get them into the state. And then really important, and again, Ayanna was alluding to this, we have to work very hard on effective communication to ensure public trust and appropriate messages. I think we all know again that, you know, with vaccine hesitancy prior to this pandemic and during this pandemic, there's a lot of mixed messages and mixed beliefs about everything from mask use and certainly to vaccines. So we want to work really hard on thinking about communications and trying to do outreach to all different kinds of stakeholders to have vaccine acceptance. Because if we get all the logistics right, but no one actually takes the vaccine, that could be a huge problem as well. So just to quickly walk through a lot of the nitty gritty. So, you know, California is a very decentralized public health system. So I sit now at the state health department, but there are 61 local health departments. There's 58 county departments in 3 cities. So at the local health department level, there are providers that can enroll. So UCSF has enrollment, all of the other different clinics can have enrollments, and there's a lot of training that happens at the provider level and storage and admin capabilities. And then each of these providers should be looking at our prioritization guidance that goes through this process I just mentioned. And I'll talk a little bit at the end too about how we propose to incorporate equity into the allocation and tracking of that. And then the doses get allocated at the local health department level to enrolled providers based on whatever their allocation that is population based at the county or local health department level. And then that gets decided to which healthcare providers that are enrolled gets decided by the local health department. And then they approve orders and forward them to us at the state for processing. And then we review those, submit those orders to the CDC. The CDC reviews those state orders and they submit the orders to the manufacturer. So for example, the Pfizer vaccine is already now in distribution. So once those orders are processed, for example, Pfizer has done its own distribution and started that, and Moderna will be using McKesson as a distributor. And then it ships from distribution centers directly to California providers. The transport of the vaccine from the factory goes again directly to the healthcare setting sites, at least for this, especially during this stage. And as you all likely know, with Pfizer specifically, there are really unique cold chain requirements during transport. So this ultra low temperature that's needed for the Pfizer vaccine. So that's really important. And we did have 2 temperature excursions and the shipments that came on Tuesday in the state, but they were quickly replaced by Pfizer. So then California providers are starting to receive vaccine. We had shipments this week on Monday, Tuesday, and Wednesday. And again, of course, at that direct level, at the provider level, we need to have these freezers available for this ultra low for Pfizer, and then more routine cold storage for the Moderna when that comes. And then starting to vaccinate, as many who has seen in the media and probably directly at UCSF this week. So these are just what the pallet shippers look like for the Moderna vaccine. And then this is just giving you kind of a broad picture of what we think will be happening over kind of now through 2021. As far as right now, we're in this very kind of small amount of limited doses that are available, and we have a constrained supply. So we're really doing targeted administration and allocation. As you all know, you all as healthcare providers are in that priority 1A. And then we are actually, as we speak, our Community Vaccine Advisory Committee was working with the Drafting Guidelines Committee yesterday to think about phase 1B and who are in those other next high priority critical essential workers. And then in phase 1A is also our high risk for morbidity and mortality. So the residents and staff at skilled nursing facilities and assisted living facilities and residential care facilities for the elderly. As we get more supply over the next few months, there will be more and more doses available, and then we'll have increased access. We can more broadly administer vaccine and potentially do more kind of mass vaccination clinics outside of the healthcare system. But really right now, we're really relying on the healthcare system and our existing vaccine infrastructure to administer vaccines now. And then eventually, it should be more of a routine, kind of incorporated into all of our routine vaccination schedules. So we have submitted our first orders. We initially had an order allocation of 327,000. As I mentioned, we've had distribution and shipments this week. And, you know, again, it's all in motion now, which is really, really exciting. And just to review more than nitty-gritty, so what our Drafting Guidelines Allocation Work Group and then got input from the Community Vaccine Advisory Committee did was take the broad group of healthcare workers. We have almost 2 million healthcare workers in, actually I think it's 2.4 million healthcare workers in California. So tier 1 and the highest priority are acute care, psych and correctional facility hospitals, skilled nursing facilities again, as I mentioned, and then paramedics and EMTs, other kind of first responder, medical first responders, and dialysis centers are in the highest tier. And then we just started, again, talking about this next level. The broad groups that are likely going to be in phase 1B are the educational services, food and agricultural workers, and again, other critical first responders that are not the medical group. And then as many of you know, today, the FDA and the VRBPAC committee is meeting to talk about the Moderna vaccine. And then this evening, our Western State Scientific Safety Work Group is also meeting to follow up on the recommendations of the FDA VRBPAC committee as well, to just review again that what data has been made publicly available to make sure no steps were skipped and that the process was transparent. So our planning assumption for the rest of the month is that we'll get over 2.1 million first doses. There is some back and forth you're hearing in the media as well about that Pfizer allocation. You know, our most recent communication from the CDC is that there is a slightly lower allocation for the rest of the month. So we're still trying to sort that out, but stay tuned on that. And then as far as the pediatric questions, you know, I think this was already covered in different ways. I think really it's just the teen ages. There's, I think, less than 200 children, I believe, as I looked at some of the trial data in the 12 to 16-year-old range. As you know, the Pfizer, or as you hopefully know, the Pfizer vaccine was approved for 16 and up. And then the Moderna, I think, is between 12 to 16. So there's very low numbers. And then one of the trial data I looked at, there was, you know, one case out of 50 or 60 in the placebo and none in the vaccinated, but it's just very, very low numbers right now as far as pediatric enrollment in vaccine trials. I think those are just sort of starting, and you know, this is the AAP Q&A on this right now. Will there be vaccine available for children before next fall and next school's year? And we're all hopeful, but we are just sort of not sure yet. But that, I think, is the other kind of, so certainly as soon as there is vaccine available for pediatric use, we will be working again through the system I just described to make sure that that vaccine is rolled out to children. I want to just echo some of the data that Ayanna mentioned as well, that, you know, we're very actively looking at schools and school reopening. We've actually, another great UCSF colleague, Dr. Bardock, Naomi Bardock, has joined us to really help us really focus on this issue, and just echoing that, you know, all the data that we're seeing shows that transmission in schools is actually very unusual if schools are following all the usual guidelines of masking, physical distancing, keeping windows open, cohorting, and things like that. So we're really working hard on that issue as well. This is just, we have a couple different websites, and trying to continue to coordinate them more and more. There's a main covid19.ca.gov website for the state, and a lot of our data is on there that you can look at, our regional data, which tier are your counties in for the blueprint tier, and also information on vaccines. And then our CDPH website also has a lot of our health officer orders. Some of our more public health or clinical specific guidance is on the CDPH website as well. So with that, I will stop, and I think we're going to open it up to Q&A.
Fantastic. Thank you, Erica. That's great. I'll just add one thing to your last slide about vaccine studies in children. I believe Pfizer is planning to do their study in children less than 12 over the summer. And I think, you know, if we build in enrollment and some follow-up, I think that pretty much tells us it wouldn't be being rolled out clinically to children by the fall, unfortunately, but at least we'll be getting data, and there may well be data in high school age children, which, you know, for many reasons, I think is even more of a priority, right, than the younger population. So we'll have to follow that as it happens. Great, so we now have at least 5 minutes to answer some questions from the attendees. So the first that was posed quite early, I think, is best directed to you, Joel, and I'm wondering if you could comment on what we know about the safeties of these vaccines in pregnant people, and then what specific recommendations are there around their administration in that population. I think you're on mute, yeah, you need to.
All right, okay.
Oh, perfect, hear you now.
Thanks. So I have to give Ted credit actually for feeding me the answer to this directly from the CDC website. So the fact is there's really, negligible information on safety during pregnancy or lactation. Let me just say, best scientific opinions are that there should not be pregnancy or lactation associated risks of either of the RNA vaccines. But again, we don't have data. And these are, RNA vaccines are not something that we've got a long track record with. So the CDC's advice is that someone who's pregnant that is in a group recommended for vaccination should consider being vaccinated. In other words, they shouldn't perceive that pregnancy is an absolute contraindication. They should consider it, but it isn't considered to be mandatory until there's, much more information on safety. Uh-oh.
Gotta get off mute. Great. And then I don't know, Erica, are there going to be do you have any kind of state-specific kind of impressions on that, giving how to advise for pregnant women, or just allowing the CDC?
Yeah, similarly, I just had sort of looked at the AAP Q&A on this as well. I think, I do think, there's no theoretical reason to be concerned. And I think, certainly we have concerns that pregnant women are at higher risk for severe complications. So I think it is, a difficult decision to make on an individual level. But again, I think there's much more concern about serious complications of disease versus the vaccine.
Great. Okay, next question that just came in that would be good for maybe Ayanna and Erica to both comment on. Recognizing that the Latinx community is at higher risk, what are the approaches to get vaccines specifically to this population? Do we have a Latinx task force to address these concerns and cultural barriers in this community?
So there is, in fact, a Latinx task force, which organized around testing, but is going to be involved in this as well. So they have made specific messaging with that group around testing and are working on messaging for vaccines, both for that community, for the African American community, and others. And I expect that we will have much more outreach and individual communication too, as they do that during testing events, which is a critical opportunity to get somebody to learn about vaccination. And so we will likely roll that out relatively soon, but I'm actually not sure about what the date is.
Yeah, and then briefly the state level, and also, of course, the data statewide has been very similar. I should also mention we just launched one of the beginning parts of our campaign for vaccination. It's called Vaccinate All 58, and there's a bunch of toolkits. And on our CDPH website, please do look at other toolkits. We have another campaign. It's more about prevention called Il COVID. That is also great. So we do plan to, we are doing some, working with partners and doing some of our own focus groups as well to work on both the Latino population and other populations to do more outreach. And then our Healthy Places Index that we use for health equity metric will be another way we'll try to follow sort of allocation and distribution of vaccine to really monitor equity and distribution.
Great. Okay, I'm going to try to sneak one last question in here, maybe just to you, Erica. Any comment on elderly populations and their lineup if they're not in assisted care facilities?
Yes, it's a great question. And my understanding is this is likely going to be discussed at the ACIP meeting this weekend. As far as, right now that next tier is looking primarily at essential critical infrastructure workers and whether or not the other elderly or other with medical conditions should be kind of in parallel in that highest tier or the next tier. So I think it is soon after as far as, but there's also a whole lot of other essential critical infrastructure workers to be considered. So I think there's going to be a discussion both at the ACIP level, and then we'll be bringing that back in California as well to discuss where they're going to be in sort of this phase 1B and or phase 2. So more to come.
How about teachers? That'll be the last comment, and then we'll close.
Teachers are definitely an active discussion for this phase 1B. Like the educational services are in the top 3 categories right now for phase 1B to be considered. So the 3 were educational services, so teachers and childcare, food and agriculture, and emergency responders.
Great. Well, that unfortunately brings our hour to the close. I don't know, Dr. Hirsch, if you want to make any closing comments, but I certainly want to offer my thanks to our speakers. That was just stellar and really timely information, and I really appreciate your time today. Dr.
Thanks,
Hirsch.
Ted. And I want to also thank our speakers today for coming and participating in Grand Rounds. This was a fabulous Grand Rounds. And as I said at the beginning, this will be our last Grand Rounds for the year. So Happy New Year, happy holidays to everybody. We'll see you all back in January. And in the meantime, we've got a lot of exciting things to look forward to, as was described today. So everybody be well.
Thank you. Bye-bye.